Today, we're taking a guided tour of a rare and pretty complex genetic condition called Coffin-Lowry syndrome. So let's jump right in. To get a sense of just how rare we're talking, the estimated prevalence is about one person in every 50,000. So yeah, this is not something you hear about every day.
And that very rarity makes it a fascinating but also incredibly challenging genetic puzzle, not just for the families who are living with it, but for the entire medical world trying to understand it. So let's start putting some of those pieces together, shall we?
All right, first up, what exactly is Coffin-Lowry syndrome? We're going to look at how it was first spotted all the way to how we define it today. So the story actually begins back in the mid-1960s. You have Dr. Grange Coffin, who in 1966 describes two boys who weren't related but had these really similar striking anomalies. Then, just a few years later in 71, Dr. Brian Lowry reports on a family that has a similar but clearly heritable syndrome. By 1975, the medical community puts two and two together and realizes, hey, we're looking at the same thing here. And so they officially named it Coffin-Lowry syndrome to honor both of them.
So what is it really? Well, at its core, CLS is a genetic disorder, and it affects a lot of different systems in the body. But the four big hallmarks, the things you'll almost always see are some level of intellectual disability, a set of very distinctive facial features, developmental delays, in things like speech or motor skills, and various abnormalities in the skeleton. Okay, so now let's get down to the nitty-gritty. The genetic cause. And this is where a crucial X factor comes into play. The cause of CLS has been pinpointed to mutations in one very specific gene, RPS6KA3. And here's the key. Its address is on the X chromosome. Now, this gene isn't just a random bit of code. It's absolutely vital. It helps our bodies create a protein that's a key player in cell signaling, especially in the brain. We're talking about things as important as learning, memory, and even the basic survival of our nerve cells. Now, the way this condition is passed on follows a pattern called X-linked dominant inheritance. I know, that's a mouthful, but what it means, in simple terms, is because that gene is on the X chromosome, a mutation in just one copy of it is enough to cause the disorder. And as you're about to see, this has totally different implications for males and females. And this slide just illustrates that perfectly. So think about it. Males have an XY chromosome pair. They only get one X. If that single X has the mutated gene, well, there's no backup plan. The impact is going to be much more severe. But females with their XX pair have a second, healthy X chromosome that can often step in and compensate for the mutated one. This is exactly why females with CLS tend to have milder and much more variable symptoms. So you might be thinking this is always inherited, right? Well, here's the twist. The answer is actually no. A huge majority of cases, we're talking 70 to 80%, are something called de novo, which just means they're brand new mutations. The genetic change happens completely spontaneously, often in a family that has zero history of the disorder. Pretty wild. Now that we've got the genetics down, let's talk about what CLS actually looks like for the people who have it. And the most important thing to remember here is that it's a spectrum. Seriously, no two cases are ever exactly alike. This quote from a really important review paper by Dr. Alistair Hunter just says it all. He says that while cognitive and neurodevelopmental issues are a consistent part of CLS, the actual severity and the profile of those issues can vary widely. And that's the key word. This chart really puts that variability into perspective. This is from a review of 72 cases, and you can see right away developmental delay is nearly universal. It affects almost everyone. But then look at the other symptoms. Kyphoscoliosis, that's a progressive curve in the spine, shows up in about a third of the cases. And then you have these unique drop episodes, which we'll get to in a minute, seen in a smaller but significant group. It just goes to show how differently the syndrome can show up. So when doctors are trying to make a diagnosis, they often look for a whole constellation of physical features that can actually become more obvious as a person gets older. This can include things like a prominent forehead, eyes that are widely spaced and slant downwards, and a broad nose. A lot of individuals also have large, soft hands with fingers that kind of taper at the ends, along with short stature and that spinal curvature we just mentioned. Okay, now we have to talk about one of the most unique and honestly challenging symptoms of CLS. About 20% of people with the syndrome experience something called stimulus-induced drop episodes, or SIDES for short. These are sudden, super brief collapses where all their muscle tone just disappears. And they're often triggered by something totally unexpected, a loud noise, a surprise touch, or even just a moment of excitement. The person is fully conscious the whole time, but they just fall. So, with all that in mind, how do families and individuals manage life with Coffin-Lowry syndrome? Well, the key thing here is that it absolutely requires a coordinated team approach. And let's be really clear about this up front. There is no cure for Coffin-Lowry syndrome. So all of the treatment, all of the management is really focused on tackling the symptoms, trying to anticipate complications, and just maximizing a person's quality of life. And you do that with a whole team of specialists. That care really stands on four main pillars. First, therapies. Physical, occupational, and speech therapy to help with all those developmental delays. Second, proactive medical monitoring. This means regular checkups with specialists like cardiologists, neurologists, and orthopedists to keep an eye on everything. Third is educational support, usually through things like individualized education plans or IEPs. And finally, and this one's so important, is family and community support. Things like genetic counseling and connecting with support groups who get what you're going through.
So finally, let's talk about the long-term outlook and why ongoing research is so incredibly critical. What's the path forward?
The prognosis can vary quite a bit. A lot of individuals live well into their adult years, but life expectancy can be shorter because of serious health complications. For instance, one study that followed a specific group found that among those who passed away from complications of the syndrome, the average age was around 20 and a half. This really highlights the serious health challenges that need that constant, careful monitoring we talked about. And this brings us to a huge critical point. It's something Dr. Hunter pointed out all the way back in 2002, and it's still true today. We have a real scarcity, a paucity, of long-term information on adults with CLS. To really understand the full life journey with this syndrome, we just need so much more research and long-term follow-up. The story of Coffin-Lowry syndrome is really the story of just one of more than 7,000 known rare diseases. And each one has its own unique puzzle, its own challenges. Understanding this one journey really forces us to ask a much, much bigger question. How can we as a society get better at supporting every single individual and every family that's trying to navigate these incredibly complex paths?